Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
This week we are with Dr. Gara, who is going to talk about winter pediatric respiratory problems. Hello, Edit. How are things?
Hi, Aebhric. Thanks very much, and welcome everyone for this week's podcast. As you just mentioned, we will discuss pediatric respiratory and specifically croup and bronchial asthma. And the reason why I chose these two topics for this week's podcast is the reason because in wintertime, these two conditions, and especially the croup, is extremely frequent amongst children and amongst toddlers. So croup and bronchial asthma, they are not the same. So they are extremely different conditions, different pathology, different pathophysiology, and we will talk through these today. So let's first start with croup, and then in the second part of today's discussion, we will turn to the bronchial asthma. So croup, what is it? Croup, this is a viral disease. It is caused by a viral infection. And due to this respiratory virus, there is an inflammation of the upper airway tract in these affected children. A croup is also called a laryngitis or tracheitis or bronchitis. So it is the inflammation of the larynx, the trachea itself, or smaller bronchi. It's really important to outline that this is caused by a virus, by an infection, and this is one major difference when compared to the pathology of bronchial asthma. This croup disease, it's really common amongst small children, especially from the age of 6 months up to 6 years. And after around 5-6 years, children just simply, they are not prone to get the condition again. So what's going on? There's an inflammation of the upper airway tract, and due to this inflammation, there is some edema and some tissue swelling in these upper tract, which leads up to the major symptoms of the disease. And after the age of 5 or 6, the children simply, they grow larger trachea or larger larynx, and the tissue swelling is not causing any pathology after that age.
They stop getting croup at 6 just because of the size and lumen of the trachea.
Yes, so it's not just that one, so it's not really black and white, but that's one major reason why they are not getting the symptoms. It can be another reason that they are not getting the virus itself. They have some immunity against the virus, but it can also happen that they get the croup virus and still they don't develop the tissue swelling, or the tissue swelling is not causing the typical symptoms anymore.
I remember that on the ambulance, you can tell croup as you walk into the house. And it's that seal barking thing. Why is such a definitive cough?
Yes. So yes, you are right. It's really, I would not say easy to diagnose, but it's a physical exam, so you don't need an X-ray. You only need to listen, to see the child acting, do the physical exam, always follow the ABC protocol, and with those results at your hand, you can definitely diagnose a croup, and you don't need any other diagnostic tool at your hand. You don't need imaging. Of course, you can put on a saturation meter to define the severity, but you are right. You walk into the house and hear that barking cough, which is really a key feature. And the reason is, just I mentioned the swelling of the upper airway tract, and that swelling is causing a bit of stenosis of the inflow and outflow of the air. That's the reason behind this barking noise. So this is one really typical symptom. Others are usually this stridorous sound is experienced in inspiration. When you also hear at the expiration, then that's a really severe croup. So first it develops by inspiration, and later on in expiration as well, the stridor itself. Then, of course, there is some dyspnea, some increased work of the breathing, which is, I recommend to have some, for the students to have some background work, and look for a video of a child with increased work of breathing, because it's once you've seen, you will always remember. So they use a lot of extra muscles within the rib cage, and you can see those muscles working. And they also use extra muscles of the nostrils, and you can see those tiny poor children using that extra work to get some air. And of course, they try to get a body position, which makes them easier to breathe. I've never seen a child lying down or lying on the back with croup. It's easier for them to sit up. Maybe they bend a bit forward as well to help the breathing.
It's always interesting to watch the new paramedics and the new EMTs try to lay a child down with this, and because that's what we're taught, isn't it? The patient lays down on their back and you treat them.
Yes.
They'll get hit in the face by the child because they don't want to lay down. They want to be in that tripod position.
Yes, sure. And in general, I recommend that when you have a pediatric case and you are there at the scene with the child, just try to not to intervene. So avoid any intervention which is not 100% needed. So if the child is sitting in the mother's lap, that's the best. Please not to try to sit them to a chair or whatever. Just leave them in their environment as much as possible, and not intervene. Just do those which are extremely compulsory to do for your examination. One more symptom could be fever. Usually it's not a high fever or not present at all, but mostly croup is accompanied by fever as well.
And how do you know the severity? How do you know when it's a severe case versus a mild case?
Yes, for the severity, we have an objective method to define, and this is the croup score. So we have a scoring system to define the severity. So when you, in a remote condition, you need to use to see what are you dealing with, and to have a plan in your mind that how will you manage this patient on a long term in the remote conditions. If you are lucky and you are not a remote medic, then with the help of this scoring system, you can define whether the patient needs immediate hospitalization, or whether you can treat at home, or maybe with the help of the parents, leave the patient at home. So this scoring system, it contains 5 points. The first one is the sound of the inspiration. The second one is the stridor itself. The third one is the barking cough. The fourth one is the increased respiratory work with physical exam. And the fifth one is the cyanosis. For each, you can give 0, 1, or 2 points. 0 is when your physical finding is normal or the cyanosis is not presented. And with this scoring system, if the child scores 6 points or more, then that's a really severe croup. If there is 3 to 5 points, then that's a middle range, and 1 or 2 points is just a mild croup.
So why isn't there an SpO2 reading or a blow-by EtCO2 reading?
I recommend to use this to guide the treatment because if there's decreased SpO2 below, I would say I will recommend 92, below 92%, then you need to definitely give oxygen support to the child. Most updated guidelines, they don't recommend routine administration of oxygen. So when the SpO2 is above 92, then you can wait and see how the case is developing and redefine the oxygen therapy if needed.
If you had blow-by EtCO2 capability, would you see the shark fin as you would as asthma?
If it's a really severe croup, then yes, because then it's affecting the expiration as well. In mild croup, in my experience, the EtCO2 is normal.
So what can we do for this casualty?
I would like to outline, first of all, that these children are responding very well to the therapy. A croup, it can be a really frightening disease, and mostly when it's an attack first time, then the parents can also be really frightened. But the good news is that the response to the therapy is really good, and really, really severe croup cases are a rarity. So, I mean, severe by respiratory support or intubation or prolonged hospitalization are rare. It's frequent, and it's happening during wintertime really frequently amongst toddlers. So let's talk about the treatment. So as I've just mentioned, the environment of the child is really, really important. So try to remain calm, try to keep the child and the parents also calm, try to avoid causing any distress to the child, because crying and distress, it just makes the breathing work and the croup itself more severe. So that's the point 0 in the treatment, to guide the environment and the child itself in a good way to avoid more distress. It's not easy. It's a difficult task because the child is sick, they are frightened of the medic, the parents are frightened. So we need some routine in this to be able to guide the family as needed. Okay, so we discussed the oxygen therapy. If needed, then give oxygen. And the key in the treatment of croup is the steroid treatment. And mostly when given early, then the hospitalization can be avoided. So you can give either prednisolone or dexamethasone, and you can administer orally or in a rectal administration as needed per the child. If they can swallow and if they are cooperative, then oral administration is good and is enough. If there's no severity according to the croup score, then this is the basis therapy. You always give some fluids if needed. So if there's any sign of dehydration, you can talk with the parents as well to hydrate the child as needed. And one more thing, which is an interesting hint, and this is also really useful for the remote conditions. This tip just tells you that the cold air makes the work of the breathing work easier. So the cold air itself just makes this tissue swallowing a bit not so severe, so it makes it easier to get the air through those swallowed tissue. So what can you do? You can simply dress up the child and open the window if it's winter time, and for a couple of minutes stand there and let the child take deep breaths from that fresh cold air. I've also seen good results with opening the fridge and just standing there with the child, or sitting there with the child for a couple of minutes. I've looked for evidence, but no evidence for this. This is from experience. And yes, if we just try to put together, so the cold air, the cold amounts of air, they definitely can cause some vasoconstriction in the upper airway, and by that vasoconstriction, the swallowing itself decreases. So again, no evidence, but this is a useful tip, and also useful for those parents whose children suffer from croup, because unfortunately this is repetitive. So once a croup, then that child is prone to have several more attacks up to the age of 5 or 6. So some parents are experts in treating croup.
I think, if I remember right, in the 80s and 90s, we would get ice, put it in a container, screw it into the oxygen delivery device, and let the child breathe the fumes of the ice.
Yes. Yeah, like it's a more sophisticated way of breathing in cold air. Yeah, that's also a good way. I've just would try to avoid too cold air, and not to administer too cold air. But yes, that's also a good practice.
And what about inhaled epinephrine?
Yes, inhaled epinephrine comes when there is a severe middle or severe croup case. So in those cases, you need to use the inhaled epinephrine, which you can put into the oxygen device, or if there's any. Yes, I also wanted to mention that always, if the child has any device at home, could be an oxygen delivery device, could be an inhalation device with ultrasound, then I would recommend to use their own device, because that's familiar for the child. They've seen that before, they've used it before, and it's in general, the therapy is more successful with their own device.
Makes sense.
Yes.
I saw a paramedic get one of the kid shows up with something soft and cuddly, don't they? And he put the end of the oxygen tubing under the arm of this teddy bear, and then gave it to the child. And that's how we got the blow by, to be able to calm the child down.
Yeah, that's a really sweet way. And yes, we need to have some tricks in hand to calm the child, to help them remain cold, and the parents can help a lot as well.
About the epinephrine, in austere environments, the countries that we work out of, you can get 1 to 1,000 epi vials easily, but you can't use that, can you? How would you use a 1 to 1,000 epi vial and get them to inhale it?
Yeah, there's no problem with those. So if you have simply the mostly used 1 milligram epinephrine ampule, then you can easily dilute and put 0.5 milliliters to 5 milliliter, and then with that solution, you can do the inhalation, and I would recommend to let it for 10-15 minutes. That's the use of it.
All right.
If you need to repeat, I mean, if the stridor and the barking cough is still present, then you can repeat. I would recommend to have at least 10, ideally 15 minutes of break, and then you can repeat the epinephrine inhalation. Of course, you look for side effects, you monitor the child, you look for tachycardia. If any rarity you find a child with a heart disease, then try to avoid or use with just really deep care the epinephrine.
So are we ready to move to asthma?
Yes, I think so. So the hint is with croup is the cold air, and be familiar with the croup score, because it's really helpful for your diagnostic physical exam as well. And again, I would like to outline that no X-ray needed. It's a physical diagnosis, physical exam, and mostly frequent amongst toddlers. And as just you beautifully said, you step into the flat and you can diagnose from the barking cough. And now let's turn to the bronchial asthma. Bronchial asthma is a complex disease, and the major pathology or major pathophysiology, it's not infective. So a child who is suffering from bronchial asthma, they develop it sometimes in the toddler years or a bit older. Later on, they bring it up to their teenage years, and mostly then in the adult years, the symptoms are not so frequent, or the whole disease is just healing or disappearing. So most likely you won't see the first asthma attack of a child with your ambulance. It happens at one point of their life, but mostly we see the acute exacerbations of a chronic asthma. What can be the trigger? Really, really, really long list. So it could be a pollen, it could be allergy, it could be, however, it's not an infective disease, but it could be a virus or a bacteria which is affecting the respiratory system, and for that reason, they also develop an acute exacerbation of their chronic asthma. It could be change in their general environment. It could be dust. It could be another infection, gastrointestinal tract infection as well, can exacerbate the asthma. So it's really long list for the triggers. The key is that this is a chronic condition. The child and the parents, they are really well familiar with the disease. They know the history as well. Most children, they take a couple of medications. They have inhalative drugs. They have tablets for long-term treatment. So they are really familiar. And if you see an asthma attack with your ambulance, you should spend a couple of minutes, if it's not a really severe case, to really quickly, or not a minute, but just 30 seconds, to talk with the parents and try to get the history. How long is it going on? What kind of medications the child is taking? When was the last severe attack? And how often they get the attacks? And what is the usual outcome of the attacks? Because you need to have in your mind, you need to see whether it's their first attack, whether it's their, fifth attack in 2 weeks, because the general image is different.
So what would be a red flag as you walk in and you see the asthmatic child? What would be some of the red flags that make it serious?
Yes, very important question. So red flag would be when you walk in and with a Blick diagnosis or with a ABCD quick exam, you would see that the child has severe respiratory distress. And by that I mean that they have a resting dyspnea. They can't talk, not a word is coming out because they are so dyspneic. It could be that they have an impaired consciousness. It could be that their breathing rate is really low, or the work of breathing is really irregular. Again, if you do the EBCD, then with the pulse rate, the heart rate, if at those measurements if you get the red flags, then I will definitely immediately start resuscitative treatment. It's important to shortly discuss the normal breathing rates in pediatric conditions, because for those who are not dealing with children every day, it could be sometimes tricky to define whether there is a tachypnea or not. So just quickly, a newborn, the normal breathing rate is around 60, but not more than 60. So it's around 50, 60. And with the increase of the age, the normal breathing rate is decreasing. So up to 1 year, the normal rate is up to 50. And then between 1 to 5 years, the normal breathing rate is up to 40. And then over the age of 5 up to the age of 10 or 12, it's around 30. And if you have a teenager, then you can quickly interrogate or ask the weight, and some teenagers can easily weigh as an adult, so then you can treat them and use the adult doses of the medications.
The age, is it 12, 13, or is there a cutoff on age that we can treat them as an adult?
No, I would not recommend to use the age as a cutoff. I would recommend to use the weight. So, and then again, I can't really say, or do you know, Aebhric, is there the weight to cut off, like to say that below 50 kilograms, it's a pediatric protocol, and over 50, it's adult protocol?
I haven't heard that, and because there's so many obese kids now, it would be a challenge to. I mean, we don't have the problem here in Europe too much, but there are some 60 kilogram pediatric kids out there.
That's right. So I would say that around 50, over 50, 55, 60, then you can treat as an adult.
So how do we look at the severity of asthma?
Many scoring systems exist, but they are really complicated, and not just one, as we just learned, one for the croup. So by the physical examination, you can gain tons of information, and with those, you can define the severity. And here I would like to mention one approach. So you look for the signs of dyspnea. You look for the ability to talk. If they can talk like we are talking now, then that's normal. If they need to stop for a while, and I'm trying to imitate now, then that's a mid-range. And if they can only say some words or unable to talk, then that's a really severe asthma. You do the ABCD, the breathing rate, the heart rate. You do the Glasgow Coma scale or any other scale to define the consciousness. You look for the signs of increased breathing work, the use of the extra muscles for work. You use your oxygen saturation meter, and can also use the ETCO2 to define the severity. And one interesting physical exam is the pulsus paradox, which is not easy to diagnose or not easy to recognize if there's not much experience. But if this is presented in a very prominent way, if there's a prominent pulsus paradox, then that's a severe case. So the reason is that there is so highly increased pressure in the thorax itself because of the expiratory obstruction, then it's affecting the preload of the heart. If this is severe, so if there's a huge pressure in the thorax, then this pulsus paradox is represented, and then that's a severe asthma. But again, I would say that you won't try to define the severity only by the pulsus paradox, because it's not easy physical diagnostic tool.
Yeah, it takes a while to get both pulses at the same time, and you're focusing more on the breathing. Yeah, fair one. Breathing.
Yes, sure. Yes.
It's interesting. I've noticed for croup as well as asthma, you mentioned that quick assessments are pulse respiratory and SpO2, and at the college we have CPRO, which is capillary refill, pulse respiratory, and SpO2 is a quick assessment. What would we find on the cap refill for someone with croup or someone with asthma?
I would say that in most cases, in both cases, the cap refill would be normal. So I would not count, or I would not wait for an increased cap refill if it's not a really severe croup or asthma. If it's severe and it's hemodynamically affecting, and the patient is for any reason in a severe respiratory distress and really close to the need of respiratory support, then yes, then it would affect the hemodynamics, and then we might experience cap refill prolongation as well.
So focus on the pulse respiratory, SpO2, and capnography when you get it.
Yes, so in general, the cap refill is not so useful, not so informative if it's not a severe croup or asthma.
I guess it's still CPRO instead of capnography, instead of capillary refill is capnography. We won't rename our CPRO here at the college on that one. So treatment, how do we treat asthma?
Yeah, so the treatment it lies on how severe the asthma itself. So if it's not so severe attack, then I would recommend to look for and ask for the general medications they have at home, and see whether they have a medication you want to administer, and if yes, then again I recommend to use their own medication, because the child is familiar with that. They know how to use, they know how to inhale. It's with these kind of inhalative drugs, it's really important to use them the right way, because if not, then the medication itself is not reaching the bronchioli, and then it's not effective at all.
Plus, with that, it's a great advice that you use their equipment first, because in an austere environment, we don't want to go through our kit if we have a chance to use theirs.
Yes, and in general, it's really good to use their own medication. They know it, they know how to handle, they know how to administer, and on the market, there is really a wide range of inhalative asthma medications, and the kit itself is completely working differently. So for one, you have a liquid container, and you put in the liquid and then grab it, and then it makes the inhalation, and you need to inhale, that's it. And another one, it has a capsule, you need to open the capsule, put it in or take it out or whatever. So they work completely different, and they have the medication you want to use, then use their own device. That's really yes, it's an important advice. I agree. So what kind of medications you would like to give? In a mild asthma, you would like to give a short-acting beta agonist. So what is it? It's mostly salbutamol. So you want to give this short-acting beta agonist because it is a really good way to dilate the bronchioli and to make the expiration easier and to get relief from the asthmatic attack. Most patients, I would say all patients with chronic asthma, they have one medication at home which contains salbutamol. So look for it and use that. You can repeat twice or 3 times at the start, and then monitor the patients, and in 20 minutes you can repeat again because it's short acting. The half time is really, it's around 15-30 minutes, so you can repeat, and you need to repeat to handle the patient in a good way. If this short-acting beta agonist is not enough or the attack is ongoing, then you can try to use, again, steroids. And again, it can be administered orally, or if there's a toddler or small child, it can be administered rectally. And you can also administer it in inhalative way. And I would say again that almost all patients with chronic asthma have an inhalative steroid at home amongst their package of medications. So look for that, find that, and use that if they have it. So this was the mild cases.
Some of their steroids is purple, some of them are brown. What's the difference between the two devices they have at home?
I've seen many. So what is the brown and what is the purple? I don't know. I mean, I've seen whole range of steroids, inhalatives ones. Most of them contains methylprednisolone. Yeah. Do you know more about the brown and the purple? Or?
No, I just remember working on a city-based ambulance. It's just kind of random what they're going to have. Some of them are round, and you have to break the capsule and then they inhale it through the yeah. So yeah. It's just complete random.
Yeah, it's kind of random, and it's tricky for us, for the medical providers as well, because sometimes the patient knows that device better than us because they use it almost every day. So they can do it in a second and inhale it. So let them do it, I would say. And you have to know your device, which you have at the ambulance with methylprednisolone. For any reason, if the patient doesn't have it at hand, or you are in a remote condition and have one nebulizer or one device with a container or whatever, so you need to know your device, and the patient, don't worry, they will know their device and they will know how to use.
So how do we deal with severe?
If the SpO2 is below 92, then you need to administer oxygen. You can repeat the short-acting beta agonist more frequently in 10 minutes. I wouldn't repeat it even more frequently than 10 minutes. So 10 minutes is around the maximum. And you can also administer another medication which is called ipratropium, which is a cholinergic inhibitor, which acts together with the beta agonist. If the patient is not reacting to these, then you can move on. And what else we have? I really like magnesium, and in my experience, it helps a lot. Yeah, I can't really remember. I had a really old lady. She was in a really severe condition, and we needed to intubate her. But otherwise, magnesium was really helpful in my experience with severe asthma attacks. So you can administer it IV as an extra therapy upon those we've just mentioned before. Another one is the aminophylline. I'm not sure how widely is it used. In my place, it's still loved medication again. But according to the latest guidelines, latest asthma guidelines, it's not routinely recommended. So the aminophylline, how much experience do you have with it?
That's a new one. I just had to quickly Google it as a bronchodilator, but that's not something we had in the formulary.
Okay.
Various places I've worked.
I don't know the reason, but for some reason it's frequently used here. I'm in Hungary, and but according to the guidelines, it's not routinely recommended. So if there's a severe attack and not responding to any other treatment, then you can try. The problem is that it has really frequent side effects as tachycardia and also other arrhythmias on the heart, and sometimes even causes some convulsions. So that's what I've just learned about the side effects, and that's the major reason why it's not recommended in the routine guidelines.
Is there any other bronchodilators you would suggest?
If it's so severe that you need to intubate the patient and give respiratory support, then the tip is to use ketamine as a sedative and analgesic drug. And the reason is because it has some effects on the bronchial muscles, and it has some dilative effects. So it can, again, cause bronchodilation, the ketamine. So this is the tip, to use ketamine if you need to intubate. We all know the side effects of the ketamine, the hallucinations, the tachycardia, and also it's interesting that despite the ketamine is the recommended analgesic to choose, the ketamine has a side effect that it is increasing the bronchial secretion, which is not needed in an asthmatic attack. So, but still available guidelines and the available evidence in the literature shows that the ketamine is the safest and most effective one when you need to intubate.
So would you do epinephrine as a last-ditch effort before an RSI?
Yes, you can. Yeah, you can try. If it's so severe asthmatic attack that it would not respond to all the previous we've mentioned, then at that point you can turn to epinephrine, and you can even try administering it intramuscular or subcutaneously if it's a so disastrous situation that you don't have an IV line. Then you can try. The outcome would not be really beneficial if it's so severe that you need to turn to the use of epinephrine, because all the other drugs, they are so specifically acting on the bronchi itself. So the beta agonists, they are defined to dilate the bronchi, the magnesium again. So if those are not working, then the chances are really low with the use of epinephrine. But yes, we can try that as well.
So you'd prefer epitromium bromide over epinephrine because of that?
Yeah, definitely.
So we've intubated this severe asthmatic child. What's next?
The respiration itself, the respiratory device has to really carefully be tailored in order not to cause more harm for the child. And you would use a bit smaller tidal volume than usual because the lungs, they are already overinflated in an asthmatic attack. You try to use a decreased respiratory rate if it's tolerated, because again, you don't want to still overinflate those lungs. In terms of the PEEP, you can't fix, or you can't solve an asthmatic attack with the increasing of the PEEP. So the other way around in the guidelines. So try to use as low PEEP as possible, because with the increased PEEP, the bronchi are already overdilated and you can cause more severity. And if there's a severe overinflation and severe pressure increase within the lungs. The most severe side effect of respiration after intubation could be a cause of PTX.
So you mentioned a lower level of tidal volume. Would you go below 6 mil per kilo, or would you stick it at the bottom end of 6 mil per kilo?
I would try to stick at 6, but again, you monitor your patient. You have the SpO2, you have the end-tidal CO2, and if they are stable with tidal volume below 6, then you can try. And the guidelines are saying that use as low as tolerated, because that's the most helpful for your lungs, for the patient's lungs. So none of us are expert in pulmonology and in respiration of severe asthmatic patients on a longer term. And we all know that the time the patients spend with us in the ambulance on a respiratory machine can define their later outcome. So I would say that if the patient is stable with lower levels of tidal volume, then go as low as possible, because that's the best for the lungs.
Now, when you say low PEEP, how low are you talking about? So generally, the transport vents that we have and paramedic, they stop at 10, and you have to actually release a lever to go above 10. So I know it's not going to be higher than 10, but what PEEP would you be looking for?
In a child, I would not, in an asthmatic attack, if the machine is suitable to get that setting, I would not go above 2 millimeters of mercury, and in an adult, maximum 5.
So two PEEP for pediatric and 5 PEEP for adults. Wow.
Yeah, but again, if the device is not able to tailor it so sophisticatedly, then it might be better to use any PEEP than to use too high PEEP, even for a pediatric patient, because then it's extreme harm for the lungs. If there's a high PEEP, 10 millimeters of mercury on a pediatric lung in asthma, it's severe.
So a lot of the transport vents that we're seeing in austere environments have 5, 10 or higher, and there's no 2. I'm sure the Hamilton and some of the higher end ones can do that. So you're saying if we have a choice between 5 and 0, you're going to say 0.
Yes, I would say 0. I would choose 0. Yeah.
And your IE ratio, would you set to 1 to 2?
So you can prolong the expiration to let the lungs get the relief. You can tailor it again as needed when you monitor your patient, and the aim is to have as prolonged expiration as tolerated. And thanks, because this is crucial in asthma.
Any other variables that we can do for this casualty?
If it's so severe that you turn into a CPR situation, then think about the possibility of a PTX, because it might be that by spontaneously or as a side effect of your mechanical ventilation, the patient suffered a PTX, and it might be the reason of the collapse and the reason of the situation turning into a CPR situation. So think about this possibility. Another one is try to avoid bag and mask ventilation if possible, or just use it for a really short time. I'm not sure who is using RSI to intubation or what protocols the listeners are using when there's a field intubation, but try to avoid bag and mask ventilation, because it's not effective in an asthmatic attack. The side effects are increased with bag and mask ventilation.
So that's not a tidal volume problem. You're saying that's just an efficiency problem. You can't be efficient with an asthmatic patient.
Yes, yeah. So the earlier the intubation itself is performed, that's the better for the patient. So it's really hard to effectively get the breathing with a bag and mask ventilation, and you just pump more air into the stomach, and then it's just getting in a more complex situation.
Indeed. Well, it's one more reason to always have an ultrasound to look for tension pneumothorax on the cat. It's part of the H's and D's. Once you go into CPR, you got to do a rule out to see why they ruined cardiac arrest.
Yeah, that's important. And you also have to think about some side effects of the drugs you've used. They can cause malignant arrhythmia as well, but that's not so frequent. So I would count more on the possibility of a PTX than a malignant arrhythmia. And if there's a malignant arrhythmia, the patient has already have to be on a monitor. So you would just simply recognize that on the monitor. But the PTX is tricky. And yes, having an ultrasound is a brilliant way to recognize it, even in a CPR situation, and handle it accordingly.
So that's been very informative. Edit, what would your clinical pearls, what would your take-home message be for the croup and the asthmatic pediatric patient?
Yeah, the take-home message would be to not to intervene more than really needed in a pediatric patient, because that makes disaster for the whole family, disaster for the child. They get in more distress, and the croup itself and the asthma as well will be worse. I promise. So yes, as you just mentioned, your tip with teddy bear, try to have some similars in your mind, and don't be afraid to use it when you handle a pediatric case, because that's really important to let them in their environment relax as possible. The croup, it's extremely frequent amongst toddlers, easy to diagnose, and responds really well to therapy. The asthma, the summary would be that those patients, most of them are chronic patients, so they know their disease, and they also know when the attack is more severe than usual. So trust your patients, use their own medication and their own devices in first-line treatment if they have the medication you want to use, because they are familiar with that and they can effectively administer or inhale those medications. The severe asthma, sometimes, unfortunately, it's fatal. So use your medications as early as needed. And if unfortunately it turns to CPR, then think about PTX.
Thank you very much, Dr. Gara. This is definitely a topic. As remote medics, we don't see a lot of pediatric patients, so this is a very valuable podcast.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, Corum.org.